introduce a really esteemed speaker, Dr. Robert Goulart. Dr. Robert Goulart is currently, as you see on the screen, Professor of Pathology at the University of Massachusetts Memorial Health and Chan Medical School. Dr. Goulart has held numerous leadership positions. He is the past president of the American Society of Cytopathology, and he has served on numerous committees and commissions, including the Committee to Determine Consensus Guidelines for the American Society of Colposcopy and Cervical Pathology. So I think that this talk is being given by a real expert in the field. Dr. Goulart is also the recipient of many awards, notably the Israel Davidson Award from the American Society of Cytopathology for Distinguished Service and the ASCP Mastership Award. So welcome, Dr. Goulart, and the title of your talk certainly generated much interest. So thank you for agreeing, and over to you. Thanks.
Thank you for such a kind and warm introduction, Dr. Michelow, and it's been wonderful working with and meeting the IAC Central Office staff, Carmen and Allison. Thank you so much. It is a wonderful opportunity, pleasure, honor for me to be with you this morning. When Dr. Z first asked me a number of months ago to give a talk, of course, I graciously accepted, absolutely honored to do so. And I thought to myself, well, rather than talking about the latest, greatest molecular test or a new immunostain, et cetera, why don't we go back to the basics? Why don't we go back to what we all struggle with on a daily basis and what's our first love for cytopathologists, cytologists, or cytotechnologists, and other folks involved in our wonderful field of cytopathology, and that's morphology. So, and let's relate that morphology to a difficult area, a challenging area that we all struggle with on a daily basis. I know I certainly do, and that's picking up and detecting with high sensitivity and specificity cervical adenocarcinoma, very difficult to do in cervical cytology. Our objectives for today are a few. We have a really full and fun, I hope, packed agenda for you today. So I'll be sort of zipping through these slides, showing you a lot of morphology. I hope you enjoy it. I certainly enjoyed putting this talk together. We're going to be discussing, obviously, the subtypes of cervical adenocarcinoma, which, as you know, have been sort of recently stratified, rethinking into HPV-associated and HPV-independent. Obviously, we're going to be focusing on early and hopefully detectable cytomorphologic features in the Pap test to aid in early detection, to make sure that we can identify these patients as early as possible. But rather than doing this in a didactic form, I thought let's do it in a case-based analogy, a case-based fashion. So I've included 12, I think, very interesting, fairly complex cases which we've had in our institution over the past, say, year to two. And some of these have actually been in the past weeks to months. So I'm going to show you our struggles. I'm going to show you our diagnoses. I'm going to give you our direct diagnoses so you can see, not in an abstract fashion, but what we actually call these cases and how we work with these cases. I have quite a few acknowledgments. It's a wonderful opportunity to be here. Obviously, for the IAC, my good friend, Dr. Z, for the kind invitation. One of my colleagues, Pamela, for sort of donating one of her interesting cases to this presentation. And first and foremost, a wonderful Rawan Taboud. Dr. Taboud is PGY4 in our department. She will be our next GYN breast fellow. She was instrumental in pulling some of these cases, getting the whole site images done, taking images, which I think you'll find quite exemplary and photogenic. And I am very much indebted to her for this presentation. No significant disclosures. I wish I did, but I don't have any financial relationships. So again, we're going to be talking about real-world cases in this presentation. I'm going to be giving you our real-world diagnoses, and I'm really going to be focusing on challenges and outcomes. I'm in Massachusetts, as you know, and in the States, for the most part, we've been using liquid-based cytology for the past, really since the late 90s. There are still some sections of the country and some populations that are being screened by direct smears, but all the images I'm going to show you are by liquid-based cytology. In our lab, we use thin prep technology. I'm going to be showing you a number of immunostains, and of note, all of those immunostains are fully validated, whether they're on conventional cell blocks or stelliant cell blocks. Okay, so let's start obviously with the WHO for classification of our cervical and GYN tumors. So just to stratify in this slide that really we should think of these cervical adenocarcinomas in two buckets and then everything else. And the two buckets are HPV associated. And when I say HPV, I'm always talking about high risk. As you know, there's no reason, no indication for any low risk HPV testing. So HPV is always high risk, and that's HPV associated or HPV-A. And the second bucket, the more difficult bucket actually to identify, will be HPV-independent or HPV unassociated. And I'm going to be showing a number of those examples as we discuss it. But let's get right into the cases, and here we go. So the first case, 31-year-old woman with a normal uterine bleeding and had a ThinPrep Pap test of note, HPV positive, and we do partial genotyping in our laboratory, and she was HPV-16 positive, and went for a stelliant cell block in our preparation of her side. So here we are, some images. You can see these hyperchromatic crowded groups, always difficult groups to spend your time on and focus up and down three-dimensionally. But you can see, and I hope you can see my arrow, you can see relative hyperchromasia to these groups overlapping. You might see microacinar or rosette formation, hyperchromasia, definitely a jumbled group with an aberrant chromatin population, stratification here with a common luminal border. Show you a few more images just to show you the chromasia. That's an angry, aggressive appearing chromatin pattern. With actually just adjusting my screen here, actually a bit of a background of sort of wet fibrin and obviously partially crenated red blood cells that you might even wonder about a tumor diathesis. Just another image to show quite a bit of anesonucleosis and an irregular honeycomb presentation. Again, the anesonucleosis is giant cell variability in size and shape from one cell to another, that aberrant chromatin population. So this is a relatively straightforward case to begin with that I think everyone would be comfortable with. Feathering, you can see on the tissue, on the cell block, on the cell group edges. Just another picture, a beautiful picture of a rosette. Rosettes are quite specific to this diagnosis, which I'm sure you're getting at. So this is the cell block. I can't stress enough, and probably the biggest take-home message for this talk is I find cell blocks, whether they're conventional cell blocks or stelliant technology cell blocks, if you have a stelliant machine at your institution and available to you, are extremely useful in AGC or atypical glandular cell Pap tests. And here you can see a cell block group with a rosette formation with a floating mitosis and the cellular overlap. Just some more cell block pictures, single cell necrosis, small but prominent nucleoli in some groups, and a background, again, of sort of wet fibrin, and you wonder about could there be a tumor diathesis in the background. Another lower power picture of the cell block here. One thing to be noted, you might say this P16 is sort of relatively equivocal, not that strong. You have to be very careful. One of the caveats is with stelliant cell blocks, you have to be careful that P16 may be a bit on the weak side. So when it should be positive, or you anticipate it positive, it's a bit on the weaker side. Be careful. That could be showing you a P16 positive adenocarcinoma. And of course, we know this patient was HPV-16 positive. Here you can see a high KI proliferation rate, and monoclonal CEA was positive. So our diagnosis for this was on the Pap was positive for malignant cells, adenocarcinoma clearly, the morphology and the entire picture favored endocervical origin. We thought it was AIS at least, with the overall finding suspicious for invasion based on the number of tumor cells present and a background that suggested question about tumor diathesis. Here's the cervical biopsy. You can see the same irregular cytology, crowded groups. You might wonder even, could this be an irregular infiltrative pattern? Is this AIS versus invasion? Here's a higher power. One note about this HPV-associated endocervical adenocarcinoma is the blue mucin, and we'll note that later on, but just let's note that how blue the mucin, the tinctorial qualities of the mucin, single cell necrosis, floating mitosis, apoptosis, etc. The P16, as you can see in this formalin-fixed cervical biopsy, very strong diffuse, no question about that. So let me just move this a little bit over, oops, excuse me, and move there we go. So the P16 and monoclonal CEA positive, P53, which you should have, a low threshold for also staining for if you have that availability, was a wild type, and ERPR and Vimentin entirely negative. So the diagnosis for this was endocervical adenocarcinoma in situ, usual type. The immunostains reported, and this broadly involved the epithelium. There was no definitive invasion, but of course this patient would go for cold knife cone diagnosis, cold knife cone procedure. Whenever there's a glandular abnormality, please have your clinicians do a cold knife cone, not a lead procedure, as the cautery is sort of devastating to the cytomorphology at the tissue edges. We did find, as was somewhat suspected in this case, an area of stromal invasion, relatively superficial and limited, still the histologic pattern B, with extensive AIS approaching the margins. So let's talk. This is sort of the easiest case of the group. I'm sure you're all relatively comfortable with this case. But let's talk a little bit about endocervical AIS, HPV associated, typically in the 4th decade. Be careful because you often have HSIL associated. These are difficult cases. This is a relatively straightforward one, but they're subtle. Why? Because the location, high in the endocervical canal, the cytology is relatively well defined, but still challenging. And colposcopy is difficult. So often the clinicians are unsure of exactly what's going on colposcopically. The vast majority of these will be HPV high risk, 16 or 18 positive. HPV 18 in particular, people think of it with AIS, but you can also see the general relationship with AIS, but also certainly you can see HPV 18 in just HSIL without HSIS also being present. These are cellular specimens, typically. Your hyperchromatic crowded groups, those are the groups you really need to stress, spend your time. They're difficult, focus up and down, and just the cytology, as we discussed, feathering, rosettes are quite specific. You don't see rosettes in lower uterine segment, shedded endometrium, or typically in benign endocervical cells. The nuclear overlap, enlargement, stratification, et cetera, hyperchromasia. The mucin depletion, you can see it, this quote-unquote endometrioid type, which obviously brings in the differential of endometrioid adenocarcinoma. But again, that wouldn't be P16 positive. If it's not high grade, it wouldn't be HPV positive, as we saw in this. The floating mitoses, the apoptosis, are typical. Goblet cells or intestinal differentiation is very, very helpful, but not specific. We can see that, as we'll see, in HPV-independent adenocarcinoma, and rarely these can be ciliated. In my career of 35 years, I've seen just one case myself. Invasive is adenocarcinoma, HPV associated, is unfortunately increasing in relative prevalence. We're doing a really good job with squamous cell carcinoma lesions, but these are still difficult to identify, and these patients are still progressing to invasive carcinoma, unfortunately. Again, the 4th decade, as you know, we have silver patterns for invasion, non-destructive, or an expansile pattern, which is pattern A. You cannot have LBI in that pattern. Any LBI takes you definitely out of pattern A into a B or C, and then obviously destructive invasion in B or C. The usual type is the predominant pattern. That's the type that we saw in this situation, with less than 50% mucinous cytoplasm, but there's also a relatively large bucket, 25% of mucinous type, and we'll be talking about some of these subtypes just to come. And as we know, the classic sort of cytomorphology coupled with immunohistochemistry is strong block like P16, P53 wild type, ERPR completely negative, and CDX2 may be positive, which can be another challenging area. When you are suspicious for invasion, look for the single cells. The more single cells you have, the more adhesiveness you have, the more pleomorphism you have, the more suspicion you should have for invasive carcinoma, particularly when you have mixed architecture, not just sheets. When you have sheets, single cells, three-dimensional clusters, syncytial groups, when you have that combined morphology, really be suspicious for invasion. And large nuclei, the more macronuclei you have, again, the more worrisome for invasion. Tumor diathesis, which we saw subtly here, is really relatively difficult in liquid-based cytology, because that's what the liquid-based cytology does. It removes the fibrin, creates the red blood cells, removes red blood cell fragments, so it can be much less conspicuous in liquid-based preparation. Obviously, if you see AIS or HSIL in the background, that really supports cervical origin, again, P16 HPV positive. If you don't see an in situ component and you're worried about invasive adenocarcinoma, or that's your diagnosis, really best to defer to a fractionated D&C for that determination. So with that relatively straightforward case, let's move into the next case. 33-year-old woman, history of AGC, but had a negative cervical biopsy and ECC, and then a follow-up Pap test again, HPV positive for HPV-16. So here we go. You might say relatively similar features to the last case, overlapping stratification, aberrant chromatin, maybe some squamoid features. You might wonder, is this mixed features of both squamous and glandular? Clearly malignant cytology, very aberrant chromatin, very clumped, single cell necrosis, an aggressive looking tumor. To show you a few more morphologies, again, very clumped chromatin pattern, extremely aberrant chromatin pattern, very disorganized, high-grade tumor, nuclear stratification, common luminal border, clearly adenocarcinoma in that, some single cells with cytoplasmic vacuolization, and more of the same. So our Pap diagnosis for that was atypical glandular cells favored neoplasia and strongly favored an endocervical origin. She went on to cervical biopsy, and you might say this clearly looks like the lesion of note, but is a bit different looking to the prior case. It's a little squamoid metaplastic appearing in this area. The mucin production is not quite apical, not quite as blue as what we saw for the prior case. Here's a bit of a higher power. Don't see quite the same high-grade cytology and histology that we saw in the prior case of AIS. You might actually note that you see little wisps of mucin sort of here and there through the full epithelium, and that's a hint to this diagnosis. Some real mucin vacuoles present, but not the same cytomorphology that we saw in the prior instance. Here's a lower power view of that cervical biopsy and the P16 that was strongly positive. And the P40 was completely negative. So there was not a squamous component. This was not a mixed AIS endocervical HPV-associated endocervical type with HSIL. This was what looked to be clearly a complete adenocarcinoma. So our biopsy diagnosis was endocervical adenocarcinoma in situ. We did not see invasion. Again, HPV-associated. Again, cold knife cone resection. But the morphology in the cold knife cone looked a little bit different. This isn't the same morphology that we were just seeing with the prior images. This is certainly more mucinous. Looks like potentially it's just a mucinous subtype of HPV-associated endocervical adenocarcinoma. Again, a bit of a higher power. Doesn't have that metaplastic appearance. Doesn't have that full thickness. Go back to that just a second. Doesn't have that full thickness mucin. Just a different morphology, but not quite the morphology of HPV-associated AIS usual type. So again, raised the issue is this HPV-associated endocervical adenocarcinoma mucinous type, not usual type, but mucinous type. So the cold knife diagnosis, we did see stromal invasion to 2.5 millimeters, was invasive endocervical adenocarcinoma, HPV-associated, moderately differentiated. We had a background of AIS, and we did have HSIL in other areas, a common finding, no LVI. Then she went on to hysterectomy, and we found out why we were finding these two morphologies. We clearly see this complex area here, and then this other area that looks different with more of a parvolocular open gland area of invasion. So going higher power to this side here, this more complex solid growth, you see what we saw in the first cervical biopsy. You see this complex, clearly invasive, high-grade adenocarcinoma. Again, the morphology here being a bit more squamous metaplastic appearance, a little bit less blue tinctorial quality to the mucinous cytoplasm, and this sort of mucin droplet vacuolization pattern. So this was very different than the other component. And so this was a combined component of HPV-associated invasive endocervical adenocarcinoma, both mixed types, both mucinous, and the type that I'm really introducing to you now, which is invasive stratified mucin-producing adenocarcinoma. So let's talk about SMILE, which you've all heard of, which is, of course, stratified mucin-producing intraepithelial lesion, the non-invasive counterpart of invasive stratified mucin-producing adenocarcinoma. This is a very difficult diagnosis to make specifically. Often these end up being AGC cases or AGC favor neoplasia and the cervical type. And here's a few, I've not seen a case like this, at least where I could prospectively make the diagnosis, but these are some representative images from your references. So again, you can see the same intracytoplasmic mucin that we were seeing, the same squamous metaplastic type features where you find some areas where that are look to be mucin depleted, not the same stratification, milder nuclear pleomorphism. The chromasia is not quite the same that we saw in the typical HPV-associated endocervical adenocarcinoma usual type, a finer chromatin, sharp subborder, no feathering, no rosettes, no palisading. So really a difficult diagnosis. So that's a subtype of mucinous endocervical adenocarcinoma HPV associated, and that is SMILE and its invasive counterpart. All right, on to number 3. And I separated this into 3A, 3B, two similar cases. So 38-year-old woman, abnormal uterine bleeding, cervical mass, so we know she's going to have follow-up of that cervical mass. Again, thin prep pap test, but this time HPV negative. And we have the cervical mass and an ECC. So I'm going to show you a number of features here because I think this is a beautifully photogenic case. But here you go. Here are your endocervical cells, obviously, endocervical glandular cells. Are they usual type? Are they reactive? Are they related to that mass? What if we didn't have a mass effect? But you can see a bit of, even from this power, a bit of nuclear atypia. And let me just bring in my marker here. Some disorganized crowding, a bit of a nucleolus, nuclear membrane irregularity, not seeing the single cell necrosis, not seeing the mitotic figures, not seeing the apoptosis, really a honeycomb pattern that might give you some features of safety, that these could be reactive endocervical cells, but very well-defined cytoplasmic borders and cytoplasmic ridges. Look at a few more images here. Again, the same nuclear atypia, and that's classic for these cases. Every group looks atypical. There's not one group that you can hang your hat on. It's clearly, frankly, malignant, but every group is atypical. Prominent nucleolus, irregular nuclear borders. Grooves were prominent in this case. That's not in the literature, but as you can see, I did see a significant number of grooves, vascularization. And the other issue is the cytoplasm is really quite clear. The tinctorial qualities of the mucin are a bit different. They're not as blue. It's more of a clear, foamy, or even pink cytoplasm. Here you see the same disorganized, mild hyperchromasia, prominent nucleolus, though, the same cells, repetitive cells, every group you look at, but not the same, overt features of malignancy. And again, the same foamy, pink, or clear cytoplasm, as you see again there. Are these benign endocervical cells? I would say not. They're just variations of the theme, same nucleus, same nucleolus, same slightly irregularity, but I bet you haven't seen a mitosis, haven't really seen an apoptotic cell. So be careful of that. These cases are not screamingly malignant based on those features. Just a few more examples. Again, the pink cytoplasm, they can phagocytize polys, as you see in this instance here, nuclear grooves, a little bit more cytologic atypia. Just enjoy the pictures, beautiful pictures for us, but devastating diagnoses for the patients whom it is our pleasure to serve and our honor to serve. So here you can see the cell borders again, etc. So this was an overt case, a number of groups. Our real-world diagnosis, we knew the cervical mass was going to be biopsied, etc. We would have additional follow-up with atypical endocervical cells. You could argue that we should have said favor neoplasia or raised the differential diagnosis, but we knew the cervical mass would be biopsied. Here's the ECC of that cervical mass, the same cytology, a few apoptotic and bodies and nuclear debris present, but not overtly malignant, but a pink cytoplasm. Not blue cytoplasm, but a pink cytoplasm. And P16 to go along with the HPV being negative was entirely negative. Interestingly, note, you have to, sometimes bring P53 into your diagnostic acumen. P53 clearly was overexpressed, greater than 70 or 80% of cases of cells. So this was a P53 mutant overexpressed pattern. So here is a synopsis of the immunostain. Again, monoclonal CEA, we felt this was a cervical primary, was a cervical mass. P53 mutated, KI only mildly increased, not increased like you would see in a usual type endocervical adenocarcinoma. P16 negative, ER/PR negative, which favors endocervical origin, same with dimension. So this case was endocervical adenocarcinoma, at least in situ. We reported the immunostains as we see, and we really suggested strongly that this was likely an HPV-independent endocervical adenocarcinoma of gastric or pyloric type. Patient went on to the hysterectomy, unfortunately, with that endocervical mass. She did have an invasive adenocarcinoma here. You can see it here, just an entirely different morphology than the usual type, HPV-associated, pink cell tumor with sort of a low grade, although clearly invasive with a reactive stromal pattern here, but not the blue hyperchromasia that strikes you from low power when you look at usual type. Here's a higher view. You really see the pink cytoplasm in this situation, mild degree of nuclear overlap, the grooving, which maybe I'll write this case up as bringing that to the literature, the prominent grooving that was present in this case that's not really been well described previously, at least to my knowledge. So this is an example of endocervical adenocarcinoma, HPV-independent gastric type. Unfortunately, it was a huge mass and was locally aggressive, as often is the case. These cases are difficult to diagnose early just because of the cytomorphology. They arise in the upper endocervix, and many of these patients present with advanced stage large tumors. And as you know, even though these tumors can look cytomorphologically indolent, they do worse, unfortunately, than the HPV-associated counterparts. 3B, sort of a related case. We just had this case a few weeks ago. 65-year-old woman, intermittent hematuria for the past year, thought to be questioned. Could this be hematuria versus postmenopausal bleeding? Again, a thin crepe pap test was high risk HPV negative, was called NILM by diagnosis, but thankfully, her hematuria persisted, and then they worked her up and found a cervical mass on her CT urogram, and that cervical mass was biopsied with an endometrial biopsy because the question of her age, could this be an endometrial primary? So we look back at that NILM pap, and these are the examples of the worst sides, the worst cells, I should say, that we could find from that NILM pap. We just could not find diagnostic material, but I think you, again, could suggest from this sort of wet blood, crenated red blood cells and fibrin, did she have a diathesis in the background at that time that should have been commented on? But we just did not see diagnostic material. And here's her cervical mass, looks very much like the prior case. Again, clearly invasive, desmoplastic stroma, but again, the tinctorial quality of the cytoplasm, I want to stress that. It is a vacuolated, clear, pink cytoplasm. It is not the blue cytoplasm of HPV associated. And here's a bit of a higher power of that, very similar to the prior case. Immunostained, ER, completely negative. CDX2, which can be quite positive in these cases. We'll talk about that in just a moment. Be careful of that. But P16, completely negative, and then P53 wild type. P53 is only mutated in these gastric types, HPV-independent endocervical adenocarcinomas, in about 50% of the time. So it helps you if it's positive, but be careful. If it's wild type, and you do that on a cell block from a pap test, be careful. It really doesn't help you if it's wild type. It only helps you if it's P53 mutant. So the final diagnosis, unfortunately for this patient, was endocervical adenocarcinoma, again, HPV-independent gastric type. I know I'm speaking to the world a bit. This is relatively uncommon in the US and other parts of the world, but for those of you in the Far East, you see it more often than the rest of us, and probably you're more expert than the rest of us. It's a difficult diagnosis to make. It's 10 to 15 years older epidemiologically than HPV-associated endocervical adenocarcinoma, and unfortunately, these often present, as I've discussed, large masses. It involves the upper endocervix. These don't come to clinical diagnosis early. Very difficult to diagnose based on pap results. Well, unfortunately, these are aggressive tumors, again, irrespective of cytomorphology. Like we saw in the first case, it was a hypercellular smear, flat, honeycomb-like sheet. They vary in size and shape, cuboidal to columnar. You don't get the stratification. Look for the foamy pink cytoplasm. Look for the distinct cell borders. The nuclear enlargement can be mild. Some of these cases are very high grade, easily to diagnose, but many of them are very subtle with very mild nuclear atypia. And unfortunately, even with that mild nuclear atypia, these are aggressive tumors. These patients do poorly. chromatin pattern is much more hypochromic than you would see in HPV-associated usual type endocervical adenocarcinoma, prominent nucleoli. The mucin does help. If you see that pink, vacuolated, clear mucin rather than the blue mucin of HPV-associated or typical benign endocervical glands, be sensitive. I really studied the mucin in cases of AGC, or when I'm wondering, are these benign endocervical cells from a polyp, et cetera, or could this be an endocervical adenocarcinoma HPV independent? Fewer mitoses, less pronounced apoptosis. The neutrophil phagocytosis that we do see is of help. Intranuclear inclusions, I really didn't see them much in these cases, but did see the grooves. And you may see goblet cell change. So goblet cell change is not specific by any means for HPV-associated adenocarcinoma. You can't see it in this type. And it can be CDX2 positive. Remember, HPV negative in these cases, P16 negative, and P53 mutated only in about 50% of cases. Watch out for CDX2 and CK20. They could lead you to, a false issue. Could this be a direct extension of a GI tumor, et cetera, or a distant metastasis? And I'll show you a case of that a bit later. HNF1 beta, again, upper GI marker, can be weak. And the classic marker for this is MUC6, but you may not have that in your IHC menu. Case number 4, an older woman, 76-year-old, last PAP normal, postmenopausal bleeding a few years ago, went for hysterectomy. No one thought this was related to hysterectomy, and then had these abdominal wall lesions. And I'm going to show you an FNA of the abdominal wall lesion, because this is a rare case. So here you go. So this is just how they look. These are the best groups that we could find, but this sort of crushed, small, low-grade blue cell tumor with peripheral palisading, difficult to see through, really not a high-grade appearing tumor, as you see some peripheral palisading and overlapping, not necessarily mucin-producing by any means. A crushed, smeared look, you might think, could this be a neuroendocrine tumor, but didn't see the single-cell necrosis, no necrotic background, didn't quite have the aggressive look of a small cell carcinoma. Here you can see a little bit of an aberrant chromatin pattern that certainly would bring neuroendocrine differentiation to mind. Here you go again, maybe a little bit of nuclear molding. Is this metastatic small cell carcinoma of the lung? Does this patient have a new primary? What's going on here? Again, three-dimensionality, small but distinct nucleolus, and aberrant, I would say neuroendocrine type chromatin appearance, and question of nuclear molding. So what is going on here? Beta cell block, and that cell block looks very endometrioid to me. That looks like a ductal type adenocarcinoma. That my first differential, if you showed me that line and said, Goulart, what do you think this is? I would be thinking an endometrioid adenocarcinoma. As you can see, very endometrioid appearing, sort of mucin depleted, if you will, single cell necrosis, a little bit more prominent in this cell block, mitotic figures, et cetera, but very, very endometrioid appearing. She's a 76-year-old woman. She's had postmenopausal bleeding. You could easily say, what was in that hysterectomy? Did she have prior known endometrioid endometrial adenocarcinoma? Again, for the cell block, but PAX-A was positive. That made sense. CD10 showed a luminal type pattern, and GATA3 was positive. And you might say, Goulart, why did you do GATA3? Well, because we went back to the history. History is always key. It is your best immunostain. It is your history. And the history in this case with HNF1 beta was, you might be getting to this diagnosis, I'm sure you are. Pan-keratin was diffusely positive. Again, P16 mosaic or negative for diffuse staining, P53 wild type. But if you thought this was in an endometrioid adenocarcinoma, ER and PR were completely negative. Naptophysin and chromogranin, both negative, worth doing because of the neuroendocrine differentiation, et cetera, all negative. So then we went back to the hysterectomy. Always, as I tell the residents and fellows, your best source of educating yourself is going to the side file, pulling prior cases. That's often a struggle to get them to do, but that's where the best bang for the buck. So this was a hysterectomy, this broadly invasive, large cervical mass. And here you can see the diagnosis, which I'm sure you've all thought of already. Here you can see mesonephric hyperplasia in the background, but this deeply invasive, palisading, relatively low-grade infiltrative adenocarcinoma, which is tubular in some areas, more ductal and endometrioid in others. But this is cervical adenocarcinoma, HPV-independent mesonephric type. These are rare HPV-independent tumors that fall into that other category. what you see on your PAP cytology, if you're lucky and you can make this diagnosis or try to be sensitive to this diagnosis, tight three-dimensional clusters, tubular architecture, small cells, small, relatively indolent cells, clear nuclei, again with grooves and indentations, and you're very lucky if you see the luminal hyaline globules, which, as you know, are PAS and music-common positive. So again, mesonephric adenocarcinoma, rare, but you will see it in your career, HPV-independent. Case number 5, 75-year-old woman. Again, these are difficult because of the patient presentation and age. Postmenopausal bleeding, be vastly more common for her to have an endometrial adenocarcinoma, but her ThinPrep Pap test is HPV positive for HPV 1845. So she goes for an endometrial biopsy. These are the Pap findings. Again, clearly malignant, I would say. Is it glandular? Is it squamoid? Difficult to say. Where is this arising? From the cervix, from the endometrium? A hint of a tumor diathesis in the background. Not large groups, clearly malignant, fairly adhesive, which would again speak to probably an invasive adenocarcinoma or an invasive carcinoma. But is this squamous? Is this glandular? And where is it coming from? Always a differential, always a difficult decision to make. Our Pap test diagnosis was positive for malignant cells, and we knew because of her postmenopausal bleeding, she was going for an endometrial biopsy. Here's the endometrial biopsy, and you may say, well, Goulart, that looks like endometrioid adenocarcinoma, relatively low grade. But as we know from the HPV, obviously you're going to do a P16, and the P16 was diffusely positive. That doesn't make sense for a relatively well differentiated, relatively low grade endometrioid adenocarcinoma. So that's your first clue. We have an HPV that's positive on her Pap, 1845, and she's P16 positive. Doesn't make sense for endometrial origin. And there's the summation of the immunos that were performed. P53 wild type. Here she went to the cervical biopsy. You might say, that looks a bit different to me. Again, we're dealing with a pink cell tumor. Is that a glassy cell change? There's fairly abundant pink cytoplasm. Clearly, unfortunately, an invasive carcinoma, and P40 was quite strongly positive, quite convincingly so. And P16 again was positive. So we felt like we were dealing with the same tumor, but had two different morphologies. And what was pulled down through the endometrial biopsy was more glandular, and the cervical biopsy was more squamous appearing. And there's the summation of the immunostains and the HPV-ish, just to make sure that we were dealing with a cervical primary. HPV associated was positive. So our final diagnosis was adenosquamous carcinoma of the cervix. Again, the glandular component usually looks relatively similar to HPV-associated usual type. That's why this sort of mucin-depleted endometrioid appearance was what was brought to our attention initially. And here's the squamous component. If you're lucky, you'll get sort of the classic previously reported glassy appearance of the squamous cell carcinoma with abundant pink cytoplasm. But be careful. Again, some of these cases are difficult to differentiate. I brought this case in because of the common differential. Is it glandular or is it squamous? And where is it coming from? The endometrium or the endocervix? And sometimes history can be make things a bit difficult and confusing. The differential diagnosis would be what we've already talked about, the invasive stratified mucin-producing adenocarcinoma, and also cervical mucoepidermoid carcinoma, where you have more mixed features. So these other cases go relatively quickly, so we'll make up time for a bit. Here's a 65-year-old woman, no Pap test for many years, and then comes in for a Pap. I'm not sure exactly why. This is a relatively old case, but had HSIL on her Pap. Goes for her lead. You can see HSIL on the surface, and then you see, my God, what is this? It's deeply invasive, clearly invasive, relatively low grade, sort of basaloid appearing tumor. I'll show you some more higher power, palisading, not overtly high grade, mitoses here and there, apoptosis here or there, some squamous differentiation, almost a cuticle-like formation, gland formation or cyst. Here's some more pictures. You can really see the peripheral palisading here. Again, the squamous differentiation and the cyst formation. So this is the rare type of adenoid basal carcinoma of the cervix. Again, a rare type of HPV-associated adenocarcinoma that almost always happens in older patients. and almost always the PAP diagnosis is HSIL because these don't involve the surface. They invade deeply and relatively aggressively, but they go infiltratively. They don't go they don't have an exophytic component. So you see these monomorphic basal cells are peripheral palisading, the cystic change, squamous differentiation if you're lucky, not much of a desmoplastic reaction. And if these are pure, these patients do relatively well. If you're lucky to pick this up in a pap smear, it's usually not detected, but these are some of the descriptors for what you might see. Just be sensitive to this case and be looking out for it when you get your leaks for HSIL, especially in an older patient who's HPV associated. Case number 7, younger woman, cervical mass, goes for cervical mass biopsies, and of note, she's high-risk HPV positive. So these are relatively few cells that were present in the pap. Here you can see them, sort of like our mesonephric adenocarcinoma, but a bit higher nuclear grade, maybe a bit more molding. I think you're all probably keying into the diagnosis. This is either an HSIL, maybe an invasive sort of basaloid adenocarcinoma, or is this a neuroendocrine tumor? And you get a hint of a tumor diathesis in the background, again, molding. But these were relatively few and not overt on the pap test. Many of these lesions are high, as we'll discuss in the endocervix, and they don't shed in the pap. The cervical biopsy showed what is obvious to you as a small cell carcinoma. This was primary to the cervix, stained appropriately. But as you can see here, these love to undermine the native epithelium. They do in the lung and they do in the cervix, so they don't shed. They often present as big masses, often have LVI, often present with high stage, and because they undermine, they don't shed into the pap. So as you know, neuroendocrine tumors are described in every site in the body pretty much, and we think of them similarly to as we do in the pancreas, in the cervix, with neuroendocrine tumors, grade 1 and 2, and then obviously the high-grade counterpart, which is what we're talking about here, small cell neuroendocrine carcinoma, and they may be mixed. So they often do not shed in pap. They're almost always HPV positive. So be careful. Many of these cases, these patients present, they do poorly. Sometimes these go for medical legal assessment, and you look back and you just do not find these cells shedded. And the patient, the family, everyone's saying, how could this large tumor not shed? I went for my pap every year or, faithfully, and unfortunately, they just don't shed, not routinely. Maybe TTF1 positive, so that's not specific for lung origin, maybe CDX2 positive also. So in some reports in the literature, you can see in these rare cases, when they look back at the PAPs, many of these PAPs were nillum. Here's another report for you. These are all given in your references. Again, many of these PAPs, when you look back retrospectively and do your due diligence for educational purposes, they were negative. So here in the last 5 minutes, we'll move along for these quick cases. An 85-year-old woman with postmenopausal bleeding, HPV negative, goes for a vaginal biopsy. You can see there's a large vaginal mass here on her imaging. And here were the cells, a bit squamoid looking, you could think. What's going on? Clearly malignant, clearly carcinoma, high grade, a lot of single cell necrosis, et cetera. What is going on here with this HPV negative tumor? Positive for malignant cells on the PAP diagnosis. And then she went for her biopsy, and you can clearly see the papillary architecture. I can tell you, if you showed me this case and said, Goulart, what do you think this case is? In a vaginal biopsy, it would be papillary squamous cell carcinoma, all day long. And let me stop this. Sorry about that. Just a quick warning. And here you see the morphology. Again, this would be typically HPV-associated papillary squamous cell carcinoma of the cervix or vagina all day long. But we know this patient was HPV negative, and P16 done on this vaginal biopsy was also negative. So what do you do when things don't make sense? You go to the history. You call the clinician. We look back at her history. She had a CT urogram in 2017. You can see a filling defect in the renal pelvis. She had a nephrectomy for this papillary urothelial carcinoma, large and bulky, of the renal pelvis. And we went back to the vaginal biopsy, did GATA3, did uroplakin-2, et cetera. Everything fit. So she was widely metastatic as we went into her history. So this was metastatic urothelial carcinoma to the cervix. So not everything that looks like a primary HPV-associated cervical or vaginal carcinoma is correct. So keep METs in mind. And we're going to talk about a few additional interesting metastases now. 77-year-old woman, history of a supracervical hysterectomy. We were told it was benign, again with a vaginal cuff mass, high-risk HPV negative, and goes for the vaginal cuff biopsy. Not overtly malignant. What's going on here? Are they glandular? You might see some well-defined cell borders. You might see some sort of pinkish cytoplasm. Again, she's HPV negative. Are we thinking HPV-independent associated adenocarcinoma? The PAP diagnosis was ASCP. That's the best we could do. Goes for a vaginal cuff biopsy. She's an overt invasive adenocarcinoma, strongly CK7 positive. This was our full workup. P16 negative, ERPR negative, et cetera, high Ki67 proliferation index. But interestingly enough, HNF1 beta, not a bad immunoprofile for HPV-independent associated adenocarcinoma, but you want to dig into the history. She had a history of Barrett's and the finding of a gastric mass. She went for a stomach mass FNA, and adenocarcinoma was identified. Again, you can see the well-defined cell borders, the finely vacuolated cytoplasm. Here's a bit of a higher power view. So here is really the exception to the rule. Here was a case we thought was HPV-independent cervical primary adenocarcinoma, and it looks like this was a gastric primary that was metastatic to the cervix. So it's never, never easy. This is metastatic gastric adenocarcinoma to the vagina. Two more quick cases. 67-year-old woman, strong family history of cancer, PAP test HPV negative. This is clearly malignant. Looks like an adenocarcinoma, fairly dark, kind of a grungy tumor diathesis background, tall, dark, and dirty, you might say. Brings up the question of could this be colonic of origin? Here you see the cell block, and you could easily go down the path of calling that an HPV-associated adenocarcinoma, maybe even an endometrioid adenocarcinoma. But again, she's P16 negative, HPV negative, PDX2 and CK20 relatively positive. So we suspected colonic primary, went and clearly had a sigmoid mass with the same morphology, again, pink cell tumor, and CK20, PDX2, PAX8 negative. So this was metastatic colorectal adenocarcinoma to the vagina. And no direct extension was identified, so this wasn't direct extension. This was a true distant metastasis. And the last case to end with, case you might never see again, but there are about 13, 15 cases in the literature. We recently had this case, an older woman with a vaginal ulcer, HPV negative, and goes for, these are her PAP findings. I've gone to oil to show you these cases. Highly malignant, epithelioid-looking tumors, tumor cells, eccentric nuclei, prominent nucleolus, just to show you a few more images. What are these cells? HPV independent, prominent nucleolus, aberrant chromatin pattern, sort of the pregnant nucleus, eccentric nucleus protruding out of the cytoplasm, single cell necrosis. What is going on here? Here's the cell block. Is it a squamous cell carcinoma? Again, vaginal, HPV independent, cervical mass. What's going on here? Tumor diathesis background, single cell necrosis. Here was the panel, negative P40, negative P16, negative for almost everything. Positive for malignant cells. We knew she had a cervical mass. She was going for core biopsy, and we wanted more clinical history. Here's the large 5-centimeter, almost destroying the cervical mass. Here's the same tumor cells on core biopsy. Here you have them on higher power, eccentric cytoplasm, eccentric nucleus, vacuolated cytoplasm. What is going on here? Here's the negative immunostain panel. With some additional history, we did these 3 immunostains. We knew it was CK7 positive. We added GATA3, and we added HER2. So the question to you is, what is your diagnosis with those 2 stains, GATA3 and HER2? We went back to the cell block of the PAP, CK7 positive, and GATA3 again, convincingly positive. So this was a case of a patient with known Paget's disease of the vulva. The clinician thought that was a total red herring, totally independent from the cervical mass. They thought this was a cervical primary. Goulart, you're crazy to raise Paget's disease, but this patient was Paget's mimicking of primary cervical mass. There are a few case reports of this in the literature. She's undergone HER2 therapy and is doing relatively well. So keep METs in mind if things don't make sense. Be careful, P16 is used in two instances. Is it HPV associated and is it high grade? P16 positive does not mean HPV associated. It could just mean that it's a high grade tumor. And dig deeply into the clinical history. So these are the cases that we've discussed. I hope you've enjoyed them. When we look back at the WHO, again, think HPV associated, HPV independent, but not every HPV independent case is going to be the classic gastric type or pyloric type adenocarcinoma. These are the cases that it's been my pleasure to discuss with you. The take-home point: this is challenging. This is an area where we all suffer. We all have a difficulty. So don't feel bad if you do. It's difficult to balance sensitivity and specificity. We don't want to overcall AGC in our PAP test. It's a significant patient workup, not only the anxiety for these patients, but they undergo colposcopy, ECC, endometrial biopsy. It's a big deal. But if we miss a case, these cases are either benign or they're high-grade, significant, frankly malignant, and can kill a patient. So we don't want to overcall them, but we don't want to miss them also. Take your time for these cases. These are not cases to do late in the day. Inspect your HCGs, focus up and down. Maintain diligence in your HPV negative cases. Don't look, if you have the HPV at the time that you're looking at the cytology, don't disregard your HPV negative cases. The tumor diathesis may be overlooked in liquid-based cases. Share them. We do all the time. And cell blocks, whether they're stellium cell blocks or whether they're conventional, we use histogel in our own lab, are extremely useful in AGC cases. I basically try to make them in all my AGC cases. And again, P16 immunoreactivity does not equal high-risk HPV, and keep METs in mind. From the words of Dr. Clark, one of my mentors for dermatopathology, the best immunostain is a phone call. Please check your APLIS, call the clinicians, try to make these cases make sense. I hope this has given you a little bit of enlightenment to a very difficult area that we all struggle with. Just take your time in these cases, make your cell blocks, and I think you'll do fine. These are selected references for your reading. We've grouped them by subject matter. And with that, I will end